everyone. In this video, we will be talking about small bowel obstruction and large bowel obstruction. So to begin with, let's start with small bowel obstruction. So let's start with the question regarding small bowel obstruction. A 62-year-old man is brought to the emergency department with complaints of nausea, vomiting, crampy lower abdominal pain, and distension over the past 2 days. His last bowel motion was 4 days ago. His wife tells you that he has been unable to eat anything for the past 24 hours due to repeated episodes of vomiting. He has a history of peptic ulcer disease, hyperlipidemia. His current medications include thiazide, diuretics, atorvastatin, and pantoprazole. He had a history of appendectomy and surgical repair of a perforated peptic ulcer 8 years ago. His temperature is 36, respiratory 22, heart rate 96. Mucous membranes are dry. Abdominal examination reveals a distended abdomen with increased bowel sounds, a tympanic note throughout the abdomen, and tenderness on deep palpation over the lower abdomen. The rest of the examination is unremarkable. His initial blood work reveals marked electrolyte abnormalities. On obstruction, series done in the ED reveals multiple air fluid level in the small intestine consistent with the diagnosis of small bowel obstruction. There is some air seen in the distal colon. What is the most appropriate next step in the management of this patient? So this is the X-ray. The air fluid level, this is small bowel, consistent with small bowel obstruction. So in this case, the next step would be to stabilize the patient and admit him for observation. So what are the clues that directs you towards small bowel obstruction? So this patient has signs and symptoms of small bowel obstruction. Complete obstruction of the intestinal lumen leads to dilation of the stomach and proximal small intestine. This causes abdominal distension, nausea, vomiting, and intermittent abdominal pain. That's exactly how this patient presented to the ED. And postoperative adhesions formation is the most common cause of small bowel obstruction, with a history of prior abdominal pelvic surgery. This patient had a perforated peptic ulcer repair 8 years ago. Some of the less common causes include hernia, neoplasm, volvulus, intussusception, stricture formation in patients with inflammatory bowel disease. On a CT scan, you see air fluid level like that, okay? And partial small bowel obstruction should be initially managed with observation and supportive treatment. If the patient fails to improve in the next 24 hours, early surgical intervention is recommended. And also remember that the small bowel obstruction is less severe compared to large bowel obstruction. So let's go through the management. Patients initially need a conservative supportive care. You'll put the patient on NPO. You start with IV fluids, NG or nasogastric decompression, and bowel rest. You will also correct electrolytes. If the patient does not improve, a bowel follow through with gastrografin is done. Patient who fail to improve clinically after 48 hours of non-operative treatment may rule out need for surgery. Okay, just to rule out surgery, the need for surgery, you do this gastrografin test if the patient does not improve with this initial therapy. Now, who are the candidates who go for surgical intervention? Patient who presents with peritonitis or who has developed signs of concerning for bowel strangulations like systemic signs like fever, metabolic acidosis, and continuous pain. Let's do another couple of questions related to small bowel obstruction. So we have a 47-year-old woman presenting to the ED with abdominal pain. The patient states that she felt this pain come on during dinner last night. Since then, she has felt bloated, constipated, and has been vomiting. Other important point is that she has notable for hypoactive bowel sounds, abdominal distension, diffuse tenderness in all 4 quads. Which of the following is the best next step? Certainly, nasogastric tube, NPO, and IV fluids. Abdominal pain, vomiting, decreased bowel sounds, distension, diffuse abdominal tenderness, suggesting a diagnosis of small bowel obstruction. The best initial test is placement of NG tube, NPO, and IV fluids. If moderate to severe colicky, abdominal pain, vomiting, absence of flatus, distension, and diffuse abdominal pain, this suggests complete obstruction. Okay, and so surgery is followed if the patient does not improve with conservative management. So this is how these are the. Now let's go through a question like this, where the patient will need a surgery. 76-year-old woman is brought to the emergency department after being found unresponsive in her room, and past medical history significant for Alzheimer's disease. Uh, Open cholecystectomy at the age of 38 and multiple cesarean section. Okay. Now, marked abdominal tenderness and tympanic percussion, vitally unstable, and lactic acidosis. You do a CT scan which shows this, okay, and air fluid levels. Then you place the patient on IV fluids, NG tube, and which of the following is the best next step? You will send the patient for surgery. Okay, so the need immediate laparotomy and surgical management. So this patient with an extensive surgical history presents with small bowel obstruction will need a surgery because of lactic acidosis, metabolic instability. All right, and so this is an example of patients who will go for surgery. Okay, so that was small bowel obstruction. Now, moving on to large bowel obstruction. So, large bowel obstruction is more severe compared to small bowel obstruction. So, let's start with the question. A 64-year-old man presents to the emergency room for increased abdominal pain and distension. He has a history of diverticulosis and chronic constipation. He last had a bowel movement 1 week ago and has not had any flatus in the past day. He reports 2 episodes of vomiting at home. On physical exam, his abdomen is distended and there is diffuse tenderness to palpation. A CT of this abdomen and pelvis shows dilated loops of bowel and a suspicious mass at the transition point. The surgery team is consulted and he is prepared for surgical intervention. So this is a classic large bowel obstruction presentation. So how do you work up? So this patient presents to you in the emergency department. What would you do? You would definitely go for a CT scan. Okay, the CT scan is imaging choice for diagnosis of large bowel obstruction. It distinguishes between partial or complete obstruction, where you find mechanical obstructed identified, like in this patient. The mass has been identified at the transition point. Dilated loops of bowel, like here. Okay, these are dilated loop of bowels. Okay, then you would do a contrast agent gastrographian test in patients who have a bowel perforation. So when you do an abdominal radiograph and you find a dilated bowel, all right, and air under the diaphragm, then that means that there is perforated bowel. Okay, so you want to confirm with the gastrographian for bowel perforation if suspected. Okay, then a contrast radiograph with enema is needed only if you suspect a volvulus, all right, or if the CT scan is equivocal. And the buzzword for volvulus is bird beak appearance on the CT scan. So this is how it looks like. This is the bird beak. All right. So let's talk in detail about air on the diaphragm. Now, not always air under the diaphragm represents a bowel perforation. So let's do this question and let understand why air under the diaphragm and how air under the diaphragm can present in other conditions. So a 24-year-old man is being managed on the surgical floor after a laparoscopic appendectomy for perforated appendicitis 2 days prior. He states that his pain is poorly controlled and has been worsening since the procedure. The patient has been receiving oxycodone for pain control. He also states that he has not passed gas or had a bowel movement yet. His temperature vitals are normal, and physical exam is notable for tenderness over the surgical site with no rebound or tenderness elsewhere. Okay, a radiograph is performed and it shows air under the diaphragm. So, which of the following is the most appropriate next step in the management? Okay, in this case, you are going to do nothing. Okay, you just give the patient hydromorphine, ambulate, and encourage incentive spirometry. Okay, so the reason is it although typically this represents a perforated viscus, which is life-threatening diagnosis. However, in the setting of a recent surgery, like in this guy who have had a laparoscopic appendectomy, it could be a normal finding from the procedure itself. Okay, so this patient is presenting after laparoscopic appendectomy with an ileus. So, um, so uh, here the pain is managed and also ambulation and incentive spirometry. So it is expected post-operative pneumoperitoneum. So this is not a emergency. Okay, so this is all about small and large bowel obstruction. Thank you very much.